Okay, so the first part of the ortho exam is usually, you talk to the client and you pretend like you don't know they're there, but you're actually watching them and seeing, can I see them shifting weight off one of the legs? Maybe they're holding it up. Sometimes as soon as they know that you're looking at them, they won't show you the lameness, so that's the first part. And then after you've done that and you've gotten your history, it's good to gait them. When you gait them or you walk them, it's better to not have them in a harness because it can affect the way they walk. So we usually have them on neck leads and try to have the person walk next to them. And first set a walk, and then at a trot. Maybe we'll go over here. So it's good to have like a long pathway. And when you look at their back end gait, you usually get down at their level and you have them walk away. And so you're mainly looking at their back legs while they're walking away. And so she actually has kind of like a short stride or a tight gait in her back legs. And then when they come towards you, you look at their front leg. And so when they're coming towards you, we often say that we're looking for which leg they go down on, or the down on sound leg. So the leg that they go down on is their good leg. In the back, some people will look for a hip hike or for a narrow gait or a wide gait. I'll still also look for if they go down on the leg. I think that's easier for me to see than looking for a hip hike. But after you walk them, then we'll usually trot them. We got them all barking now.
All right, you ready, Riley?
And so sometimes you'll see the lameness at a trot where you won't see it at a walk. And then you can take them up or down stairs, up and over curbs, stuff like that. Maybe we'll come over here if they can't see this.
Come on, Riley.
You can take them up and down stairs or over curbs to look for lameness that will only show up in special circumstances. And then you're also always looking to see if they are dragging their feet or they have a neurologic gait. After you do their gait analysis, I'll usually do their standing exam. And if they have a forelimb lameness,
Riley,
they have to actually stand now.
Okay, good girl.
If they have a forelimb lameness, we'll usually try to,
Good girl.
I'll make sure for sure that I'm looking at their face too. And what I'm looking for, we talked about this before, but I'm looking for Horners basically, because if they have meiosis or Horners, let's say on this side, and their lameness is on this side, it could indicate they've got a caudal brachial plexus lesion, like a nerve sheath tumor or a lateralized disc or something like that. And so that can sometimes give you a hint. And then you can go through their cranial nerves, which I don't have a light on me right now, but you can check for PLRs, you can check for menace, you can do palpebral, check their ears for sensation, you can cover their eyes if you have a pen, you can check their nose just that they feel it, which she clearly does. I'm not going to do it to the other one because she didn't like that. You can move their head back and forth and look for physiologic nystagmus. They should have. And then you can try to get them to swallow, also to make sure they have a normal gag reflex. You can also just kind of look at their tongue, or some people will try to actually grab their tongue to see that normal tongue tone. We had one dog that was very obviously not normal. It was, you could like see it hanging out. Okay, then after that, we're gonna go ahead and check for cervical neck pain. There's a few different ways that people do this. Some people don't like to manipulate their neck at all, especially with like a toy breed dog. You gotta worry about flexing their neck down, because if they have an AA lux, you can potentially, the dens from their vertebral column can actually pith their spinal cord, or really dangerous. So some people don't like to manipulate their necks at all. Some people will take treats and kind of try to have them follow to look for neck pain. Some people will only palpate on the transverse processes, going down laterally, feeling for like kind of like shrugging, like pain like that, or even yelping. I personally, especially if it's a large breed dog, I will put my hand on the back of their neck and then gently bring their head up. I'll gently bring it down, and then I'll gently bring it side to side. If it's a toy breed dog, I'm going to be a lot more careful about that. I might not do it, but looking for neck pain. Then I'm going to start moving backwards, and you want them to be standing square as you support underneath them and feel for back pain. So I'm going to push along kind of each vertebra, supporting underneath them. Does she have a little bit of back pain?
Possibly.
And she just kind of reacted a little bit right there. Then the next thing I'll do is a tail jack. So lifting up their tail, kind of putting it in each direction. You can also check for perianal reflex back here. And I'll support underneath them and lift their paw here and make sure that they should be perfectly square when you do this, and make sure that they're righting their paws. When you come back here and you check their CPs and back, first of all, it's better to not have them on slippery flooring. So if you're unclear, get them on better flooring. But don't put your hand in front here, because you'll sometimes tell them to not right their foot. Support them by feeling underneath their pelvis right here, and then you can place their paw and they should right it like that. The other thing that you can do for placing responses, which I'm not going to do to her right now because I know she's got an issue, is you can pick up one of their legs and kind of push them briskly. You can do that with all four legs, and what is normal is they should be hopping before they let their foot should never cross midline before they hop. So just going over midline, that's delayed. After that, I'm going to feel for muscle symmetry starting at the front, and so they really should be sitting square. And so the easiest way in the forelimbs is you feel the scapular spines right here, and feel kind of in front and in back, and you're looking to see if one of them is a lot more apparent than the other. Then you can kind of come down to the triceps, feel in that area too, but really the easiest I think is feeling for asymmetry along the scapular spines, or really apparent scapular spines.
I'm just creeping.
Oh, okay.
I have nothing to say.
Do you mind actually, do you know where the bone box is in the office?
Yes. You want that?
Do you mind bringing it over?
Yeah.
Then I'm going to feel the elbows, and I think that the bone box will really help for this, because what I do is I feel the medial and lateral epicondyles on each side, and then I run my fingers caudally. And you can be tricked. What I'm feeling for is anything soft and poochy in here, which could be joint effusion, or that I can't feel the landmarks very well, which can be thickening to the joint. And you can be tricked when you feel laterally, because some dogs, like she doesn't have a very prominent incunius muscle, so you really feel the bony landmarks. But some dogs, like French bulldogs, they have really prominent muscles, and it can feel like joint effusion. So I really rely more on the medial side personally. And when we get this joint box, I'm going to show you what I'm feeling for. Okay. So what I'm feeling for is we have the medial side on this side, lateral side here. So when I feel medially, I'm going to feel the epicondyle here. And when I run my fingers back, in a normal dog, you can actually feel the ridge to the end of the humerus, which makes it shape like an L right here. So you should be able to run your fingers back in the bone, feel that. Then as you come back, you can actually feel the scallop here. Nothing should be in between here, except you'll feel a nerve flick underneath your finger as you go to the bone. If there's anything making it so you can't feel these borders, if it's hard, it's usually like periarticular joint thickening, like kind of chronic elbow disease, or if it's soft and squishy, it's joint effusion. So that's what I'm going to feel for. I'm going to feel for that L. I'm going to have you do that in a little bit. Then I'm going to come down and I'm going to feel their carpus, and over their carpus, I'm really just feeling for anything that's kind of puffy in that area. And you can feel both of them at the same time to compare them. Okay. When I come back to the back legs, for muscle atrophy, I'll feel over their glutes. If their pelvis is really prominent, that can be some muscle atrophy. If one side is more prominent than the other, it can be muscle atrophy. And then I'll put my hands around each of the hamstrings and quads, and I'll just feel for any asymmetry. Some people will actually like take their hands and like put it around like up in the pelvis, which is really subjective. So I'm really looking for a difference and to see if they just feel basically extra bony, like more bony than they should. Then as I come down, I'm gonna feel the knees. And in the knee, her knees don't feel totally clean.
I know, you told me.
In the knee, what I'm gonna be feeling is this is actually gonna be this knee, because this is lateral and this is medial. The patella is going to sit in the groove right here, and it's going to go down to the tibial tuberosity. So what I'm going to feel for is this area right here. So I'm going to feel the patellar tendon. I'm going to feel the femur right here, and I'm going to feel the tibia right here. And I should feel a nice triangle in here. And if it's a normal joint, the patellar tendon should be very distinct, like you could flick it with your finger or almost hook on it. If it's hard to feel these landmarks, there's usually something wrong. If it's really puffy here, that's joint effusion. And if it's just hard to feel because everything feels kind of indistinct, it's usually that there's some periarticular thickening and it's not normal. The caveat to all these things are if you're feeling like a dachshund or a chondrodystrophic breed, but she is like a normal long leg dog, so it should be very distinct. In her, it's actually not that distinct. So I think there's some change inside her knees. The next thing I'm going to do is I'm going to come down and I'm going to feel their tarsi. So what you're going to feel for here is you can feel their lateral and medial malleoli, and then you just run your fingers back to the calcaneus and to really just feel like bone. If anything is poochy here, it's joint effusion. Harder, you can't feel that, it just kind of scallops in here, then it's thickening, and you can compare them at the same time. That's most of what I'll do when they're standing. Now, the other thing that I'll do is, for me, it's easier to feel MPLs and LPLs while they're standing. So I'm going to feel the tibial tuberosity. You can run your finger up the patella tendon to the patella. When they're already out, so right now it's in, and I can tell it's in, number one, because I can feel it's in the groove, but sometimes it's hard to tell. When they're out to the inside, you tend to feel a band on the inside of the leg, and that's her quadriceps being pulled over. Hers, you can follow, and they go straight up her femur like this, so it feels like it's in. So what I'm going to do is I'm going to put medial pressure on the patella and then gradually flex and extend her knee with the same hand. That's the easiest way because it goes through range of motion. I can internally rotate a little bit, externally rotate. And I'm going to do the same thing with my index finger pushing laterally. And that's what I do in large and small breed dogs. I'll also show you on the other thing when they're standing that I'll always look at is I'll look at their joints to make sure they're not dropped. Because it's really easiest to see if they're like hyperextending in their tarsi or carpi when they're actually bearing weight. So look at that when they're, because if you have a dog who's walking palmagrade, you're going to see that when they're standing. If, let's say that this leg is a lame leg, then we want to examine this leg last, because if you examine that one first and then you create pain, it might make it hard to interpret the other ones. Generally speaking, we'll start at the toes and work up. If this were the lame leg, and we live in California, we're gonna look in between all the digits and in the paw pads for foxtails, cuts. You wanna look at the toenails, make sure that they don't have like a mass there or they pulled their toenail out or something like that, they got it caught. And then what I'm gonna do is I'm gonna extend and flex the digits. If I get pain, I'm gonna go through digit by digit, feeling for pain. At the metacarpal phalangeal joint, there are sesamoid bones, and a kind of more rare cause of lameness is they can actually fracture their sesamoid bones, so you can feel for pain in those areas. But if I don't get pain there, I'm going to move on, and I'm going to feel now for bone pain in the metatarsals. And so when you feel for pain here, you want to feel on the bony surface, not the ligament or muscular ligamentous surface. So I'm going to feel on this surface, I'm going to look for bone pain by just pushing on the bones looking for pain. When we come up to the tarsus, there are 6 collateral ligaments, 2 shorts and 1 long on each side. So we're going to test for medial lateral instability and flexion and extension. So I'm going to look medial laterally in flexion and extension because the ligaments are taught differently in flexion and extension. The other thing that I'm going to check for is if I extend the stifle and I flex the tarsus shouldn't come up. Like it shouldn't flex all the way up, it should stop like this. And that's because the calcanean tendon right here is intact. So I'm putting the calcanean tendon under tension. So I'm going to run my fingers up, make sure I don't feel any thickening on the tendon. Or if the foot does flop up this way, I'm going to feel to see if I feel a break in the tendon. Or the other thing you can do is you can grab the calcaneus. If I grab the calcaneus and the foot still goes up that way, that must be because either the calcaneus itself is fractured or you've broken down one of the joints further down. So it's not the tendon itself. Does that make sense? Because I've isolated it below the tendon. So if I go like this and now the paw's still coming up here, it's not the tendon. But if I do this and it's stable, and then I go like this and it's not stable, it's probably the tendon. The other thing you can feel for is rarely you'll see a dog who comes in with acute lameness, you feel a pop right over the tip of the calcaneus. The superficial digital flexor runs over here, and they can actually tear the little ligament that holds it in the middle, and that can be an acute cause of lameness. And if you pick it up, it's actually really easy to fix. So it's a cool one that you don't see that often. Then I'm gonna feel for bone pain. And once again, the kind of more muscular side is this side. So I'm gonna feel mainly on the inside of the tibia. And according to the textbooks, bone cancer likes to live towards the knee and away from the elbow. But I will tell you for sure, they also like to get bone cancer up here. So check everywhere for bone pain. But they say proximal tibial distal femur the most. So I'm gonna look for bone pain. And when I come up to the stifle, there's a bunch of specific things we're gonna do. One is if you do wanna look for an MPL, technically it's extension, internal rotation, and then medial pressure is the most likely to get it to pop out. And then kind of flexion, external rotation for LPLs is what they say. I find it easiest when they're standing, but some other people find it easier when they're on their side. Then what I like to do for their knees, I like to kind of be behind them at around a 45-degree angle. And what I'm gonna do is I'm gonna feel the patella and the tibial tuberosity. I'm gonna run my hand down with my finger coming over the patella onto the tibial tuberosity, pushing caudally. Because if they're already standing in drawer, you might not feel it unless you push them in a reduction. So I'm gonna push caudally. And then the biggest mistake I see people do is that they flex everything like this. What you're doing is you keep their leg straight under tension, and then I'm only flexing the tarsus because I'm basically trying to mimic a step. And I'm looking to see if it thrusts, and I can do that straight in internal rotation, and I can bend their knee and still do it without bending the whole thing. So I'm really just flexing it here. So the biggest mistake I see is people do this, when really it's this. See the difference? Yeah. Cruciate tears can have a lot of signs. When they're standing, you might feel a fusion, you might feel medial buttress. They tend to be painful in extension of the stifle. They can have thrust, they can have drawer, which I'll show you in a bit. Pain on flexion can sometimes be a meniscal tear. Sometimes you'll feel a click. You can also feel the patella tendon when you flex them, because that's gonna put under tension, looking for pain there. All those things are signs. And then the last one being drawer, I actually don't like to do to big dogs, because I think sometimes it hurts a little bit when you pinch right here. But in small dogs, I have a hard time, my hand's a little bit too big to do thrust, so I'll do it in smaller dogs. But so you feel the fibular head, which is right here. You feel the tibial tuberosity, which is the bump on the front part of the shin. You feel the patella right here, and you feel the fibula, which is back here. So you get your 4 points. And what you don't do is internally rotate like that, because you make it look like it's moving. You only move in a cranial caudal direction, and it doesn't move at all. And you can do it in flexion, extension, everything. So you just move in that direction on those 4 landmarks. Then I'm gonna keep palpating on the femur, coming up looking for bone pain. Like I said, I have seen plenty of bone tumors up here too, so don't ignore this area. When I come to the hip, I'm gonna feel for signs of hip luxation. So there's 2 tests for cranial dorsal hip luxation. One is called the triangle test, where you feel the point of the wing of the ilium. So what I'm feeling here, this hip is really abnormal, but I'm feeling kind of the point right here where it turns, which is right here. So I'm feeling the point of the wing of the ilium. Then I'm gonna feel the tuber ischii, which is back here, and then feel a greater trochanter, and it should make a triangle. So the point of the wing of the ilium is right here. The tuber ischii is right there, and then the greater trochanter is right here. And if you look, it makes a triangle, right? And so that's what you should see. If this is up here, that's suggestive of cranial dorsal hip lux. The other thing you can do is you can take your thumb. This hip is severely diseased, so it's not a great example. You can take your thumb and you can put it between the tuber ischii and the greater trochanter right here. And then you can move the femur by externally rotating it like this. And if it pinches your thumb, it's in place. But if the femur moves forward, it's luxated. So it should pinch your thumb. So if I put my thumb here and I externally rotate, it's wanting to move my thumb. The femur is not moving forward. So that's another sign. Other things is that when you put them through range of motion, they're usually going to be, just got a little mass right there, yeah. Yeah, okay. It's usually gonna be really crepitant and painful. They also tend to stand with their leg in external rotation and kind of dangling like that for craniodorsal. Now for caudo-ventral, the hallmark usually is that you can't feel their greater trochanter because it's really deep. So it's different, but they're still painful in hip range of motion. Now most dogs are gonna be comfortable in hip flexion. With hip pain, they tend to be painful in abduction. I'm pretty sure she has hip pain, so I don't want to do it. But you take the femur, and I'm just gonna slowly lift up like this, and that tends to be painful. And then they're painful in extension. But hip extension pain can be caused by hip pain. It can be caused because you're extending the knee too, so it can be stifle pain. You're extending the lower back, it can be lower back pain. And you're extending the hip flexors, so it could be hip flexor pain like iliopsoas. So one way to differentiate, isolate the knee first, look for pain on hip abduction, which will signal more towards hip. Pain on extensions more towards knee. You can look for pain on tail jacker by pushing on the LS space for lower back pain. And then you can try to feel for iliopsoas pain, which is not always the easiest thing to do. So one thing is, they say you can internally rotate and extend the hip because that's going to tense the iliopsoas. The other thing you can do is the iliopsoas is going to come off the vertebra down here and it's going to insert on the lesser trochanter. So you can try to feel towards where it's inserting and how it's coming down, kind of in the groin area, and put some pressure there. And some dogs will like really react to it. You really got to compare it to the non-lame leg though, because some dogs just don't like you being up in that area. Some people say that they'll feel for like muscle fasciculations. I don't always find it to be the most reliable, especially because when we try to correlate it with MRI, lots of times we'll think there's something there and you MRI them and it look normal, so it's kind of hard to prove. But that's one of the things that we'll look for too. That's kind of the back leg. The forelimb is a little bit simpler. Simpler in terms of there's less tests, but actually it's probably harder to figure out the cause of lameness. But you actually start the same way, kind of flex, extend the digits, look for pain by feeling for pain along the bony surface once again here. When you come up to the carpus, they should be able to flex here to here. That's normal. A lot of older dogs will only flex to here, but I would say it's pretty rarely the cause of the lameness. You can check for, they should have like 10 to 12 degrees extension, but like I said, usually that's something you can kind of see when they're standing if they're dropping their carpus. Check for medial lateral instability and extension. There's only one collateral ligament on each side, so you don't need to do an extension and flexion. Check for bone pain by feeling on the cranial medial surface of the radius up here. And remember, they like to get bone cancer down here, so we're checking for pain there. You can extend their carpus, and then you can feel the accessory carpal bone, and there's a tendon right here, and you can run your fingers up. It's the flexor carpi ulnaris tendon, looking for pain there. Then I'm going to move up to the elbow. For the elbow, don't flex the elbow and the carpus together. Try to isolate them one at a time. So only flex the elbow. The most reliable thing for me for elbow pain is flexion. So I'll flex them here and they should touch here to here. A lot of dogs will start to roll away and people will sometimes not see it, but they're trying to get away from you, and that's usually because it hurts. And so that's something I'll look for. Some dogs actually can't bend it all the way. That's not normal. Dogs who are pulling away, that's not normal. They should go like this. Like that's pretty normal. You can check for pain on extension. If you yank hard enough on any dog, they're gonna hurt. That's why I like flexion personally, because this is usually pretty comfortable in dogs. So those are the two main ones there. But there's also a test called the Campbell test. So for the Campbell test, we're going to be feeling medially. So I'm going to feel the medial epicondyle here. And then I'm going to run my finger down about 1 centimeter. And that's going to put me over the medial coronoid process right here. And I'm going to supinate and pronate the paw. And when you supinate the paw, I believe that's supination, if I'm recalling right. that's going to kick the medial coronoid process out towards you. And so when you have pressure there, that can be medial coronoid pain potentially. Some dogs react to that no matter what you do, so I kind of compare it to the non-lame side. Take it with a grain of salt, but that's another thing that you can do to look for pain. If there's like a huge difference here from the other side, that can really maybe point you down to maybe it being the elbow. Next thing I'll do is I'll look for biceps pain. So whenever you check a muscle for pain, you're trying to stretch the muscle. So the biceps runs from the supraglenoid tuberosity and starts up there, originates up there, and then it kind of runs along the humerus and inserts on the radius and ulna down here. So in order to put it under tension, we're gonna flex the shoulder and extend the elbow, and that's gonna make this tight. Then I'm gonna feel for the greater tubercle right here, and I'm gonna kind of go up and into this groove right here with my fingers, kind of like right here is where I'm gonna push, and that's where the biceps tendon is. I'm gonna look for pain right in that area. Then I'm gonna flex the elbow and shoulder, and I'm gonna feel the scapular spine, which is here, the scapula. You're a really little one. All right, so I'm gonna feel so that's the biceps tendon right here where it's coming in, so that's where we're gonna try to put pain or pressure for the biceps. Then when I flex them both like this, the supraspinatus and infraspinatus come down here, so I'm gonna feel on either side of the acromion for pain on either side, looking for pain on either of those down there. Then I'm going to feel for pain in the armpit. I'm going to palpate for pain on the humerus, checking especially the proximal humerus, which likes to hide bone cancer. I'm going to feel for pain along the scapular spine. And then I'm going to flex and extend the shoulder. So you can flex shoulder. A lot of people will just do this. The problem with doing that is that you're not just flexing or extending the shoulder, you're also extending the scapula. It's rotating with you. So stabilize the acromion with your fingers and then extend it. So I'm gonna stabilize the acromion, and now we can only extend that far. That's really checking shoulder extension. Then the last thing that I'm gonna do is I'm gonna put my thumb and forefinger on the acromion to stabilize it. Then I'm gonna hold the arm straight. I'm gonna slightly abduct, and it's a very soft end feel, and I'm looking for any pain on in the medial shoulder. So really looking for medial shoulder instability. If this arm came all the way up here, it would be abnormal. So stopping here is good. And what a lot of people do is they'll do this. And so they're rotating the arm, and that you're really not testing that. I'm really actually just kind of like bending the arm. So you got to keep their arm straight and just pure abduction, and it stops with the soft endpoint right there. That's the majority of the orthopedic exam. It's always good to add some neuro to it. So a reliable reflex is withdrawal in the front limbs. In the back legs, it's withdrawal. And they should withdraw both their tarsus and their knee, not just their knee, otherwise it's weak. The other reliable one is patella tendon. And so for that one, if I had a reflex hammer, which I don't, but if I did, you keep their knee in flexion, feel the patella tendon, and with the inflection, I don't, where's my, do you have a phone on you? The phones tend to work. This, obviously you want to do this with an actual reflex hammer, but you're going to hit right there, and I can feel her doing it. And sometimes in older patients too, it'll be a little bit reduced, but that's where you're going to hit, and it'd be a lot better if I had a reflex hammer. Those are the two more reliable ones in the back leg. You can do a biceps reflex, you can do cranial tibial, but they're not the most reliable. So those are the ones that I rely on, are going to be the withdrawals and the patella. I can show you how to do the others too. We just didn't get a reflex hammer. That's it. Did I forget anything? Okay.